it's great to be here to speak with you all. I like to give sort of this introductory lecture on sports neurology and what it is, because many people have not heard of sports neurology before, especially for applicants looking into doing a neurology residency. They're not usually familiar with the field of sports neurology. So we'll start with that, and then I'll go into a little bit of concussion and post-concussion syndrome, just as, you know, the number 1 and 2 things that I treat on a regular basis, and I think help give you all some guidance in your continuity clinics and things like that. All right, so like I said, we'll go over some background on sports neurology, what kind of things I see. We'll do some cases. We'll go over some myths of concussion and, you know, common educational things with patients that I see. So starting with this question of what is sports neurology, it is a neurologic subspecialty. The first fellowship was in 2012 at the University of Michigan. And right now there's less than 10 fellowships. There's somewhere around 7 or 8 fellowships in the country in sports neurology. And I'm happy to say that we've created a sports neurology fellowship here now, of which I'm the program director, starting for July 2022. It's got full approval. So we're starting that recruiting process now for 2022. So, it's a pretty new field. And there's obviously a lot of overlap between sports and physical activity and, you know, in neurology, in terms of like neurologic conditions that occur in the general population, like epilepsy and migraines. They certainly occur in athletes, you know, people who need to perform highly or need to, you know, be active. And so we control and, you know, keep those conditions stable so that they can perform highly. We also see patients who, you know, have had a neurologic injury from their sport, perhaps, and, you know, they want to return to physical activity, or they want to, you know, really get back to their sport. Maybe they had a concussion, maybe they had a peripheral nerve injury. You know, it kind of is the gamut within neurologic sort of trauma and in the realm of all neurologic conditions. So the settings and roles of a sports neurologist are, for settings, you know, we can be at any live sporting event. So we're ringside for boxing, cage side, if you think of mixed martial arts. We've been doing that on a regular basis through our work at Mohegan Sun Arena, where Bellator, MMA, and Showtime Boxing have held a residency so that they can, they've created a bubble so that they've been able to do that through COVID, and I'm on their ringside physician staff. So, so that's one setting. Another setting is I did a course when I was in fellowship for the US ski and snowboard team to be in their pool of physicians. So we could be slope side, we can be half pipe side, you know. So really any sort of sports setting, certainly sidelines with football. That's probably the most common thing we think of. And then of course with any arena or venue, you know, we've done work with professional bull riding. So they're in arenas in different venues and you know, at rodeos and things like that. So so there's all different settings you probably wouldn't even think about. But they're neurologically important to have one of us on standby. So the next section here is on the roles. So what types of services we can provide. So we can be things like a consultant to a team, such as a team physician, or you know, like in my case, I'm kind of an independent consultant. So you know, athletes of professional teams can come in, you know, get another opinion from me. I'm not affiliated or work for any specific professional team. So I'm kind of an outside person, which I think gives a lot of value to the athlete themselves, because, you know, I don't have any other interest in the team or, you know, working for them or any outside bias. So that's one thing. And then you can also be a consultant to a venue. So like I said, with Mohegan Sun Arena, you know, they had boxing, they have MMA, they have bull riding, they have basketball, you know, so for any of their sports at that venue, we're kind of their first phone call in terms of neurologic care. And of course, there's tons of clinical research going on in the field. And so this is also a really important role of sports neurologists to help, expand the field, spread education. That's something that I like to do, is to really be educating parents, athletic trainers, physical therapists, coaches, parents, athletes themselves, anybody, because of the public health issue of concussion in particular. So types of patients we see, I see ages 6 and up, even though I'm a trained adult neurologist. Because of my fellowship in sports neurology, we've seen certainly youth level athletes from ages 6 and up. So that's kind of who I see, all genders, and all levels of participation. So it could be, like I said, youth league, high school, collegiate, professional, retired professionals, Olympians, recreation leagues, weekend warriors is another thing. People who just, participate in, renovating their house, stuff like that. But, or maybe they work in a very physically challenging field. Like I have patients who, are tree cutters, you know what I mean? And they get injured quite a bit too. So, so really any level of sports participation, but really anybody who likes to be physically active or for their occupation requires it. Another section is kind of entertainment. So we do, also treat musicians, performers, CEOs, executives, lawyers. I have a Supreme Court judge, patient. So really there's quite a wide range of patient population that we do see. Typical kind of consults in sort of categories here for sports neurologists are really anything neurologic in athletes. Like I mentioned, migraines, epilepsy, MS, Parkinson's, dementias, neuropathy, myelopathy, et cetera, et cetera. So we're sort of like general neurologists for athletes or for this active population, which is kind of fun because you never really know what you're going to see. And even within the realm of head injuries, head injuries are all different as well. Even within the same patient, one head injury to the next is all different. So, so this is why it's kind of fun for me. Another thing is we really are helpful for, was it or wasn't it a concussion? Was it a concussion or was it a mimicker? Because there's so many mimickers of concussion, like in people with migraines, they can take a minor head impact and go into a full migraine, and then they think that, oh well, that's one of the checklist symptoms, so the trainer calls them concussed when they're really not. So we do a lot of that so that we don't mislabel patients with concussion when they're not actually concussed. So that's important. And post-concussion syndrome is another field too that patients can go on to have symptoms for years, if they're not handled right, if they're not treated properly, if the approach is not, really comprehensive, then patients can go on for many years to have symptoms from a concussion. We'll talk about that too. So other types of consults we see are, sequela of neurotrauma. So, I have seen a patient who, had a gunshot wound to the head, let's say, many years ago, but he wants to, play football, so we had to do a whole assessment, which really does include, putting him through exertion and doing serial neuro exams through different physical tasks. And, looking at the neuroimaging, if there's encephalomalacia there, what's the, and what sport it is, we have to really consider all of these things, to see if it's safe for that person to actually play their sport or not. And then again, like I mentioned, peripheral nerve injuries, brachial plexus injuries, we see all of those things as well. And then second opinion, like I mentioned before, about returning to sports after, some sort of trauma. And, that's a big one because it's, a lot of patients, especially professionals, are always toying with, is this time to retire or not, and so that decision making about retirement is really, it's a sensitive topic because their profession is their sport in a lot of cases. And, it's their identity. So, you know, when that decision is made, it's really important to consider all of the things, you know, and all of the factors. It's not as easy as, oh, you've had 3 concussions, you have to stop. You know, that doesn't really work in their world. So we do have lengthy you know, consults about that as well. And then certainly just monitoring people's overall brain health. Once somebody is in contact sports, you know, they're in college football, for example, they want to go on to play professional, but they want to get that monitoring every single year brain health examination from a sports neurologist, and we do that also where we can monitor their brain health. Okay, so to talk a little bit about concussion, so really a concussion is defined as a transient condition. So it really is caused by a biomechanical force that's imparted to the brain, and it results in really different symptoms that are because of a functional disturbance and not a gross structural injury. So that's a really specific definition. However, I think what I find in practice is that people use the word concussion to describe really any hit to the head, and that's not how it should be used. So that's some key point I want you to take away. And so really the distinction from, you know, a typical concussion for any cause to a sports-related concussion is that we're assuming they're going to go back to the risk of being hit again, unlike with car accident type of concussions, right? So what I mean by biomechanical forces, and these are some examples I use with patients because they kind of simplify things with analogies. So the brain really obviously sits in the skull surrounded by CSF. It's like an egg in a glass of water. If you shake the glass, the egg is still moving inside the water and can strike, you know, the inside of the skull or the glass at that example. The next part is really with the axons. So they kind of run in groups, you know, obviously from the cortex all the way through to the spinal cord, and they're kind of like string cheese. They can stretch and shear, you know, and pull. And, you know, so whiplash or rotational forces, especially with boxing, that uppercut is really the most punishing type of injury because of the rotational component of it. And that really gets at those axons. So another way to describe it to patients is that it's a network injury. So you know, in terms of traffic maps, I like to use this analogy. You know, this is UConn and Farmington, Connecticut now. So everything's kind of green and whatever, you know, no blockages, the roads are open, everything's moving. But if you look at Manhattan, you know, it's all slowed down. There's a lot of red. It's not that there's roads missing or, you know, structural changes. It's just slowed down. And that's really what this type of injury is. So if we talk about the concussion curve, and I use this with patients all the time. So there's a force to the brain and it creates a series of symptoms. And then over time, those symptoms resolve. This is usually 7 to 10 days, definitely by 2 weeks. And this dotted line here is the symptom threshold line, where anything above the line, the patient feels symptoms, anything below the line, they don't feel symptoms. So there's kind of this period of injury at the end where they're still injured, but they may not be feeling symptomatic. And that's where we need to do the return to play process to make sure that we're bringing out any possible symptoms so that when we return them, we know that they're back here down to their full baseline. Now, we don't grade concussions anymore. That's an old classification. My training with Jeffrey Kutcher and what is used through the AAN is really this idea of how certain we are that that's the diagnosis, okay, which I think works a lot better given that it's a clinical diagnosis. There's no blood test currently. There's no, you know, definitive imaging. There's no, you know, specific test you can do that will say yes or no. So it's a very clinical condition. So for possible, probable, or definite concussion is how we classify it. And a possible concussion is really that there's a list of possibilities. Concussion is on the list, but we don't think it's the most likely thing. So there's other things on the list like dehydration or viral illness or migraines or hyperthermia. You know, those things, maybe they have a history of migraine, or maybe they're just having a migraine. You know, that's maybe a traumatic migraine happened. You know, that's probably the more likely thing in a possible concussion. The next option is probable concussion, where there's still a list of possibilities, and concussion we feel is the most likely. And then a definite concussion is that there's no list, it's the only explanation. And so really we treat a possible concussion situationally, because again, it could be something, it's most likely something else. And then in probable and definite, we treat them as if they're concussed. Just because again, that bit of gray area, but better to, to really treat them as concussed in those categories. So how do we determine the classification is really based on two main things: the mechanism, how it happened, and the symptom course. So for mechanism, it really matters, you have to go through, and get a sense of what was the force, imparted to the brain, and always get a really good description. A lot of times in sports, there's videos. We'll show you some videos of mechanisms next. So the mechanism really makes a difference so that what kind of force that brain was under. Was it enough force for the brain to shift in the skull? We'll go through some other examples as well. And it's like, if somebody stood up into a shelf, like 2 feet above their head or something, that's not a concussion. There's no way that the brain shifted in the skull based on that scenario. So, that's what we have to really think of. In that case, it's more likely a traumatic headache. So then in symptom course, for the first, 24 to 48 hours, it really sort of develops. So, I take any symptoms that appear within the first 2, maybe 3 days, depending on the right scenario, but definitely in the first 2 days, I would take symptoms and relate them to the head injury itself, if it's a fitting mechanism. And, so here's some examples, and I said, we'll go over them too, but, headaches that resolve in 12 hours with no other issues versus, headaches with migraine features and, sleep issues and nausea and, dizziness, things like that. So there's, very different symptom courses here. And then of course, if you have a baseline exam, that's always going to be more beneficial because it'll give more validity to your, clinical impression of the situation. Okay, here's some good videos of different mechanisms. So in this one, this is at Western Michigan University. I was on the sidelines at this game. So this is the athlete in the front here that we're looking at. You'll see him, this is a kickoff return. So basically I'll show it a few times, but you'll just watch how he shifts and then what happens. So he lowers his head, takes a huge hit, spins around, arms and legs are limp. I'll show it again. So he lowers his head, huge hit, spins around even, face first, not moving arms or legs. So what happened was, now he's still on his face here, and the trainers are assessing him. And basically he had loss of motion, he had paralysis in his arms and legs, and he had loss of sensation in his arms and legs. During their assessment, we'll see now he starts to move his arms again. So he's starting to check things out a little bit more. So they've automatically hold the spine, straight, kept somebody at the head so that they can get him on the spine board. This is me and my mentor on the sideline here. I traveled with him in the ambulance to the ER, got him a CAT scan and all of that. We did his CAT scan of his neck, and that was clear. So he ended up with a concussion. But these videos really help to get the mechanism. Okay, here's another example. This was a patient of mine. So during this fight, we're watching this guy here. The guy gives a 1-2 right there. I'll do it again here. Oh, he went down, hang on. Okay, so this guy gives him 1-2, and that was it. So he laid out, and once they zoom in on his face, you'll see he has a vacant stare. He's looking into nothingness, and he can't get himself up. He can't coordinate his arms and legs. He had to sit back down like he fell over again. So, and then in talking to him after, he doesn't remember any of this. So he had a brief loss of consciousness, but he definitely had amnesia from the trauma there as well. So that's another mechanism. Now, this is a patient of mine. His dad let me use this video. This is a high school soccer player. We are watching this kid here. He gets rocked. It flips all the way back, and then his head actually bounces off the turf. I don't know if you see that. Yeah, I wish I had slow motion. So he immediately grabs the back of his head, And he had a significant concussion with, neck strain. It caused a lot of oculomotor, visual tracking issues, things like that. So, so that was that case. All right, now this one's kind of disturbing, but if we're all neurologists and future neurologists, you're gonna have to get used to some of this stuff. I won't point out who it is because you're gonna know, obviously. Some of you have seen this video already. So this athlete went into a seizure here after that fall. You can see he stiffens up completely and he's out. They'll show it again in slow motion so you can tell. He gets a lot of air and really lands on his head, and he stiffens up right there in that sort of fencer but extensor posturing for sure. Yeah, he really got rocked. So and that's why we're on the sidelines, because athletes go into a seizure, you know what I mean? You'd want a neurologist there for that for sure. So this next video is really about observation. So our job on the sidelines is to really, and even ringside or at any venue, is to be watching what's going on, because athletes, number one, they want to lie to the doctor. So we always have to be ready with what we're observing, okay, is our best first example, examination for these guys. And like I said, they want to lie to you. They're gonna be like, yeah, I'm good, whatever, and that's it. So you'll have to be able to get your objective sort of tricks here, and you'll have to know better. So on this one, so we're watching this guy here, this big guy, number 77 in the red helmet there. He got hit a second time. So he took a light hit the first time. This guy here, he took a light hit, and then that second one came from the side, and that's where he's rolling around over here. I'll just show it one more time. And that one, he just like rolled around, couldn't get himself together. So then you'll see when he tries to get up now, and the ref is checking, which is really smart, so they're paying attention. So he takes he has a misstep there. He tries to set himself back up again, try to shake it off, and then the ref picks up on it and makes sure he goes to get it assessed. So, so that was a good pickup. Okay, here's some other examples. So symptom course, number one. Okay, this person had a headache after the hit to the head, which resolved in 12 hours and no further symptoms. They had full practice that day with no symptoms produced. So if you want to unmute yourself and tell me what you think of this scenario, is it concussion or not concussion?
Is there any amnesia?
No, this is the only information you have. Concussed or not concussed? This is
No.
the symptom course.
I guess not.
Yeah, no, because everything resolved in 12 hours. And then he did the next day. We gave him a chance to do your full practice, see what happens. Nothing came of it. So they're not concussed. They had a traumatic headache, which is very common. So that's good. All right. Next symptom course. Okay, so this one, after a hit to the head, the patient developed headache with migraine features, sleep issues, persistent nausea, change in appetite, dizziness, irritability, lasted longer than 12 hours. We, if the trainer wasn't sure, let's say they put them on a stationary bike just to see what happened, and it produced nausea, it increased the headache immediately. So then they couldn't complete the workout. Okay, unmute yourself. Tell me which one, if that's concussed or not concussed.
Probable concussion.
Yeah, just concussed. That's good.
Okay.
All right, yeah, because there's just much more of a symptom course there, right? It's going on and on and on, more than a day, lasting a long time. It's not just the migraine stuff. They've got all these other features, the irritability, the dizziness, maybe their sleep, it's a problem. That's how you know there's something more going on here to the brain than just a migraine. Okay, here's another symptom course. Okay, a patient sustained multiple low impact hits to the head without producing any symptoms, but after the game, they developed light sensitivity, headache, neck pain, and that lasted for 48 hours, and then it resolved. And the patient has a pre-existing history of migraines? What do you think? Concussed?
Migraine, yeah, more likely people have.
Good, good. Not concussed traumatic migraine. And that's really important because it's like, you know, yeah, sure, it can last 2 days. I mean, we know migraines, you can have status migrainosis where it goes on and on and on for a week, you know what I mean? So, you know, but in this case, it resolved after its 2 days. It had a lot of migraine features, even neck strain. And it wasn't like one standout hit. So again, that mechanism may not have been there. There wasn't really a major hit. It was just repetitive hits to the head caused triggered a traumatic migraine. Good. Okay, I think this is the last one. So patient took a hit to the head, had no symptoms. Then on day 6, they developed headache, light sensitivity, nausea, and exercise problems. Concussed or not concussed? What do you think?
I guess not, because the symptoms just appear too late.
Yeah, exactly. It's not within 3 days, you know. So they're not concussed. That's probably something else, or, you know, they had maybe a migraine, or I don't know, they had something else happening, but it had nothing to do with the head injury. So that's good. Okay, good. Now let's go over some myths, because I think this part's kind of, it's fun for people too. Let's see, myths. Okay, so having one concussion makes you more likely to have another concussion. Okay, that's a false myth. Okay, the next one. But we've all heard that one before, right? People, that's something people, our patients, they'll all read about that on the newspaper, okay? And they're like, oh, if you've had one, you're gonna have another more easily, or your threshold suddenly changes and all this other stuff, right? That's not true at all. Okay, having more than 3 concussions leads to long-term complications. Again, a myth, not true. Having a prolonged recovery that lasts maybe more than 3 weeks from a concussion means that the next one will be at least 3 weeks, maybe 6 weeks, maybe longer, you know. Again, all of these are myths. So the main thing is with the first one, so we'll go over each one. So having 1 concussion or 5 or 8 or 10, it does not make somebody more susceptible to having another one. They're more likely, the problem is they're actually more likely to be diagnosed with a concussion, because then they become, oh, the concussion kid, you know what I mean? So they keep getting mislabeled. So everything after that is automatic concussion, a lot of times to different, you know, to GPs, to emergency room docs, to, you know, pediatricians, anybody, the athletic trainer, you know, they're like, oh, well, you had a concussion, you're probably just concussed again. All right, so that's not good. Now, the next one is there's really no magical number that would require us to say, oh, yeah, you've had this many, you must retire. Like I was saying before, that is just not easy to do, and to make that decision, especially based on the number. Because, I mean, there's NHL players, you know, ice hockey, football. I mean, these guys take hundreds, thousands of hits, you know. So, you know, you're not going to make that decision lightly, first of all. And the number is too high to even decide what would the number have been. You know what I mean? So in that case, you really have to go over every single concussion through their whole history of the standout head injuries they've had, and what is their exposure to hits. You know, if you're an NFL linebacker, you're taking all kinds of subconcussive hits, you know, all the time. Your exposure to contact is very, very high for the head. So, you know, those things make a difference. But, you know, again, nothing is an automatic retirement. Okay. The next one is that prolonged recovery from 1 concussion does not mean that the next one will be the same or longer. Oftentimes, after a prolonged recovery, the next one is totally normal, or, you know, less time, because they have early recognition, especially when they're seen by a concussion specialist early on. There's a lot of research coming out now that the sooner a person sees a head injury specialist, you know, not their primary care as much, or their ED, you know, go to the ED, you know, and follow their directions. You got to see a head injury specialist early in your course in order to have a better outcome. So so that's important too. But a lot of times that's totally not true, that the next one will be the same or longer. I've seen time and time again, the next concussion after like a 3-month or 6-month recovery, next one's real quick, 1-2 weeks, you know what I mean? Even with a decent mechanism, you know. Okay, so some other things to keep in mind are really advanced testing that we do. MRI with susceptibility weighted images, diffusion tensor imaging. We consider angiogram if we're worried about a dissection in the neck, depending on what happened. In the right context, we might do those things. There's a lot of new testing out there, a lot of research for like functional MRI and, quantitative EEG and, none of that stuff's really been shown to change the management at this point. I think there's some promise for probably, I think quantitative EEG more than functional MRIs in terms of its ability to identify different biomarkers, with concussion, but in terms of their management, it's really been the same. Then we also do sometimes neuropsychologic testing. I don't mean impact testing or computerized testing. I think those things are horrible. They oversimplify the brain and the cognitive status completely. You can throw those tests, it's really not reliable at all. For the retest reliability, very poor. But I mean a true formal neuropsychologic testing with a neuropsychologist. And we only do those in select scenarios. If somebody's cognitive complaints are really out of proportion to what's going on, or, it's not explained by their mood issues or attention deficit or other things, then we would pursue that. But otherwise, it really can be helpful for trying to identify some maybe undiagnosed depression or anxiety, ADHD, because those things will be certainly exacerbated by head injury as well. Now, this is, again, that concussion curve. And then I kind of broke it up into different phases of recovery. So the first portion is like an acute rest period. Really, it's the first 1 to 2 days. We don't tell people to just like go rest, sit in a dark room for like a week or two anymore. Although, now we don't, but there are primary care doctors, there are emergency room, urgent care physicians who unfortunately do still tell people to do that and do nothing for 1 to 2 weeks, which is the wrong thing we found from research. So after 1 to 2 days, that person needs to start doing some of their normal household duties, maybe trying to go to some classes. So that's really important. Some people don't even really require an acute rest period. Sometimes they can already start doing some things around their house. So it really depends on the person. So you have to go by their symptoms. This third phase is for graduated exertion. That's the return to play process. So we start with like a low intensity cardio, add some intervals, then agility, add some weightlifting. Then there's sport specific kind of non-contact practice, and then a contact practice. And, we try to start the low intensity cardio even before they're asymptomatic, because, that's really been shown now that the earlier you can start doing this, especially in athletes who are used to being active, that will encourage their recovery. So we want to introduce this a little bit earlier than maybe we used to a few years ago. And that's been really helpful. So, but by the time they get through this process, they have 0 symptoms and everything is all good. Hopefully even before then, I like to have 0 symptoms, and completely down here by the time they do these last couple of steps. Okay, so talking about recovery a little bit, the brain likes these basic things, okay? Hydration, sleep, regular meals, and physical activity. That's pretty standard. We ask every single patient in my clinic in sports neurology about all of those things every single time. I don't even care what they're here for, okay? But we're gonna ask them all those things because that's the easiest way to fix some problems. Then we've got, a discussion about prescription medications, right? You wanna use the minimal amount, the minimal number of medicines, the minimal dosage of medicines, okay, as much as possible. And that's really the patient preference as well, especially with athletes, A lot of times, there's certain lists that you have to be aware of for, anti-doping and, in the NCAA, there's, some rules about using a course of prednisone, you have to get these certain therapeutic use sort of releases and things like that. You have to fill out forms. So, you can do them, but, you just got to be aware of all these kind of rules that go with it in sports. Okay, so, like I was saying before, after 48 hours, the person can always do something, okay? I don't like when people are wearing sunglasses indoors after that period of time, and, I don't ever tell them to avoid things for weeks on end. Like I said, they have to avoid avoidance, okay? And that's really important. So, getting them to do more normal things will help them feel more normal. And then we avoid mood issues, sleep issues, yada, yada, yada. The whole list that goes from there, okay? So again, if we kind of go back to this curve, now this line is as if there's a period of improvement to a point, and then it either kind of plateaus or patient starts having like good days and bad days, That's really the post-concussion syndrome curve. And now this line is something completely else. So this is that they had a bunch of symptoms and then they're just getting worse and worse and worse and worse and worse. There's no period of improvement at all. It's just worse and worse and worse. And that's where you got to get them into a CAT scan, okay? Because there could be a bleed, there could be something else. That's not a concussion when it does this, all right? Okay, let's talk about post-concussion syndrome, which we now try to really refer to it as what's called persistent symptoms after a concussion, because that's really what it is. We don't call them post-concussion syndrome until like 3 months after their injury. Anything sooner than that really sort of isn't fair. So the first thing is really to be aware of that, like we said, concussion is a transient injury. It always resolves within those 2 weeks, okay? After that, the symptoms may be persisting, but it's for other reasons, okay? We'll talk about that, but that's how I explain it to patients, okay? Because they're worried that they're doing more damage to their brain, or their brain is like structurally damaged and all this stuff, but that's not the case at all, okay? Just their symptoms were not put away for whatever reason, and now it's perpetuating their symptoms, and it has nothing to do with the brain injury part. So it's not a long concussion. People call that long concussion, okay? It's not. It's really its own separate disorder. So the approach really has to be different. I use this slide a lot too, but I think it just helps and it makes a lot of sense. So if we have these like 5 symptoms, they're all making each other worse. That's what these lines are, okay? This is making this worse. This one's making this worse. This one, they're all making each other worse. It's just a web of like a mess, okay? This is the post-concussion syndrome. So you can't just say, oh, we're just going to treat your headaches, okay? And I do have patients who've seen a neurologist in the past, but they're not a head injury specialist, and they just say, okay, well, I can only do your headaches. But they're not asking about how's all this other stuff, okay? Your mood is playing a part. Your sleep is playing a part. Your lack of physical activity is playing a part. You have to ask about all those things so that you can actually treat their headaches, okay? Because it doesn't matter how much medication you give them. If they have a neck strain that nobody caught, if they have occipital neuralgia that nobody caught, if they have, I don't know, sleep problems, that's part of headache hygiene, okay? You have to ask about all these things. And it's a little bit onerous, okay, on our part, but it's going to get the person back to their life. So that's why we do it, all right? But it's important to think of post-concussion syndrome as this web or like a network of just like the symptoms are making each other worse. It's not actually related. It was triggered by the head injury, but the concussion itself is over. These are some examples of the boards that I draw out with patients in their rooms. So I have white erase boards in all my rooms, and I just go through the whole plan and I go through what's going on with their kind of concussion curves with each patient. So this was a patient I saw, I guess it was a year and a half ago, a college soccer player, and their question from the school to me was, is he still concussed from his first injury, or what are we dealing with now? So this guy had a head injury. I classified it as a probable concussion. It didn't seem like that significant of a mechanism. But he had a bunch of symptoms. They did their return to play process, and they, by history, he tells me I was 100%. I felt 100%. I did the return to play. Everything was good. Then 4 or 5 days, so 5 days later, he had another mechanism, another hit to the head that was a definite concussion. This was a real mechanism here. And then he had all these other symptoms. So by the history, getting that extra bit of history made all the difference, okay? So now we know that he was 100% recovered from that first one. This was a separate injury, And so that's where we had to talk about his acute injury and treat him from there. And then he went back to playing and all of that with college. So, but that's where what we do is different, okay? And I like to visually lay it out for the patient because they're on the same page as me then. We're all on the same page. This is the plan. This is the things that we're going to do. They take a picture of their board. They know what's going on, and they love that. Here's another example. So this was somebody with post-concussion syndrome, because like we drew out, this was their injury. And then over time they improved, but they felt like they really only got to like 60% improvement here. Then they returned to working half days, and that made their symptoms worse again. So then they were like 45% back to their baseline. And then they kind of been stuck there until they saw me. So then we went over everything. We identified what all of their components are and what we were going to do to fix them. And then she fully recovered, went back to work, no problem. So it's not that difficult, it's just that in a typical neurology residency, we're not taught any of this. This is something I really learned primarily from fellowship, and having a sports neurology program here. The residents who have rotated with me, they learn this stuff, and these are good skills, good history and examination things that you guys will be able to take with you, which is always a good skill to have, because it'll set you apart from other neurologists. Okay, and that's really important too. Okay, so this is my contact info. Feel free to unmute yourself or ask me any questions or whatever you got. Fire away.
Hello, I really enjoyed your presentation. It was really interesting. I heard a few weeks ago that a blood test came out that it detects if there's a traumatic brain injury.
Mm-hmm.
I think it measures GFAP.
Yeah.
Your thoughts on that?
Yeah, the blood test is probably, it's been FDA approved for a couple of years now, actually, but I think it's called the Banyan blood test, I think is the name of it. But good question. What it does show is, like you said, the GFAP. I forget, there's one other biomarker that they've identified with it. But what it does is look for bleeding in the brain. So it does not pick up on concussion. That's why it's actually it's gotten this idea that, it identifies concussion or mild traumatic brain injury. It absolutely does not. It only can find blood products in the brain in that way. So it helps the ER make a decision if they need to CAT scan the person or not. That's really where its value has been. But for concussion, it really does not change things. And I think they said it takes a couple hours for the test to even develop. So it's certainly not going to be like a sideline test. You know what I mean? So there's definitely a lot of limitations in the way to use that test. But it does not help with concussion. It really just tells them if there's blood, no blood kind of thing. Yeah, but it's marketed as if it's for concussion, which is unfortunate.
Interesting. Thank you.
No problem.
Have you worked with any sports that are like underwater or water related sports?
Yeah. I've had patients who are divers, who I had a patient a year ago. She was a diver in college, and she just kept getting headaches a lot easier with diving. And it ended up that her neck was very unstable, just because of neck strain and different things. Her mechanics with her neck was actually creating cervicogenic headaches, but they couldn't figure it out. So I always do a neck range of motion examination, and I palpate the trapezius, the paraspinals, the suboccipitals, and even the occipital grooves in the back of the head to look for occipital neuralgia, for example. So she got physical therapy for her neck, and she did great. So, but water sports, I have patients who are crew team, really any kind of water sport, you can name it.
Cool, thank you.
Yeah.
Dr. Stephanie, this is Faisal. I have a question. suppose like patient had a street fight and
Mhm.
concussion or he just fall on the ground. Does that comes under sports neurology or it comes under general neurology?
That's a good question. I would say, like I was saying, anybody who's had a head trauma should see a head injury specialist within neurology if possible. Because like a general neurologist, like I said, in a typical, neurology training, they're not going to get experience and exposure to head injury. A lot of times, especially because in residency, if you're inpatient, a lot of the ER consults for head trauma, they go to neurosurgery for whatever reason. So you don't get a lot of the head injury action except in your outpatient continuity clinic, but now at UConn and at Hartford Healthcare, because I have this program, the residents rotate with me. This is, a good thing so that you guys can all have those skills for when you go out. If you decide to do general neurology, at least you have more exposure from this type of a program too. So, so that's a difference. And like I said, there's only, for fellowships, there's like 8 programs that are fellowship programs for sports neurology in the country. There are other neurologists that do sports and have sports neurology programs. But again, for actual academic fellowship training experience, there's only 8 in the country.